In this issue of the Running Specialist Report, we'll go over using progressive tendon loading exercises for Achilles tendinopathy. And as many of us know, Achilles tendinopathy is one of the most common ailments that runners get. And there's a evidence-based approach. There's a lot of research behind Achilles tendinopathy rehab, and I want to share the step-by-step process with you so you know how to help your patients with Achilles tendinopathy. So first off, research continues to support progressive tendon loading for Achilles tendinopathy. And progressive tendon loading is something that is definitely very prevalent in the research right now. Now, progressive tendon loading for Achilles tendinopathy is going to include isometrics, isotonics, heavy slow resistance training, and plyometrics. And we want to rank the order of different exercises, different Achilles tendinopathy exercises, based on their load index. This is going to be the best evidence-based way we can give patients a progression of Achilles tendinopathy progressive tendon loading. But it's hard to figure out what your exercise dosage should be, where to start patients on exercise, how much to give them. Those questions commonly come up, and it's hard to know when to progress them to plyometrics or higher level exercises. And that's where this comes in. So we first want to take this step by step. We want to start with a period of load management, potentially isometric exercises that progress to isotonic exercises as well. You can start those isometrics and isotonics also at the same time based on tolerance of the patient, and then progressing to heavy, slow resistance loading, and then plyometric exercises. So let's talk about how specifically we can do this for the Achilles. Well, there's a couple of important things to note before we talk about that. First off, we want to limit patient symptoms to 0 to 3 out of 10, both during the exercise and 24 hours following. But it's hard to know how much load capacity that Achilles tendon has. How do we do this? Well, we want to do a standardized single leg heel raise, and that's going to give us an idea of their strength level and their tolerance to exercise. So single leg heel raises are going to be 60 beats per minute, so 30 reps per minute. Very important to keep it at that speed. And then they're also going to go through full plantar flexion as much as they can with every single rep. We want to make sure they don't compensate at the trunk, the hip, the ankle, the foot, and the knee must remain straight. The reason why is because we really found that it was 12 less reps on average when someone did heel raises with the right form. If they go too fast, they incorporate the stretch shortening cycle, so they basically get the muscles to lengthen fast and then contract harder, and that is going to be more like plyometric training. We don't want patients to do that. We want to get a pure idea of not only their strength, but their tolerance to activity. If they're having pain with these exercises, we can consider having them do this test double leg. We can even do it as a single leg isometric raise for time. We can also do double leg isometric raises, and then lastly we can do seated heel raises as well. So we can adjust this based on the person's tolerance, and that gives us an idea of what we want to start them with in terms of their loading exercises. We also want to identify how much strength they have and how much tendon capacity they have, so we can give them an appropriate exercise. If they can do 25 heel raises without pain, that is going to start much higher level than patients that can do a double leg seated heel raise at maximum. So what do we want to do here? Well, we want to progressively load the heel raises. Heel raises are so important for Achilles tendinopathy. It's important to talk about their specific progression. Now in early rehab, we're going to give isometric heel raises and isotonic heel raises. Remember, we keep those isotonics slow, especially in the beginning, 60 beats per minute, 30 reps per minute. Start with a slow and low reps in volumes, and then we want to progress from double leg to single leg, with a goal of this early step 1 rehab being 3 sets of 15 repetitions max without pain. Then we go to the middle rehab, and we are giving them heavier, slow resistance training. This is going to be really helpful to be able to get their strength to improve. Again, still slow, 60 beats per minute. We're going to progress from that 3 sets of 15 repetitions max to 3 sets of 6 repetitions max with weight, as long as it's tolerated by pain. Now we can increase the speed here and start to get into plyometrics, but as we start to introduce plyometrics, we want to make sure the patient has adequate hip, knee stabilization. We know that the Achilles can be aggravated by weakness in the glutes, weakness in the quadriceps. And then something like a slow jog can be a really good start for someone starting to introduce plyometrics. But we need a way to rank Achilles tendinopathy exercises. And that comes into the load. Now there's 4 different tiers of load, and this is really interesting research from Baxter et al. This is a really interesting way to divvy up how patients do exercises based off of load. Now it particularly looks at the loading peak. That's what I'm going to show you here. But there also is the loading rate and impulse. Those 3, loading peak, loading rate, loading impulse, are going to all make up the loading index. The loading index is going to be how much load the Achilles is undergoing during these exercises. But loading peak is going to be the peak load placed on the tendon during the exercise. The loading rate is going to be the speed at which the load is applied to the tendon. And then the loading impulse is the total time spent loading the tendon. So with all that being said, what do we want to start patients with, especially if they're at a low tendon capacity and a lower availability of strength as well? Well, we've all heard of seated heel raises, double-legged. Those are a good start. That's going to be about 0.5 of loading peak percentage of body weight. And then we're going to add in more and more exercise here. Now, it's important to note that these can be performed both isometrically and concentrically. Isometric exercises are indicated for folks early on. Now, isometric exercises have been shown by Ebony Rio to be able to reduce pain levels with Achilles tendinopathy. However, that's inconsistent among patients. So if isometric exercises are hurting or causing a flare-up, bring those patients off those isometric exercises. But we should add isotonic and isometric at the same time, because the isotonic is going to really improve our Achilles tendon capacity. So we're starting all these exercises and we're gradually progressing them. Our tier 2 exercises, you can see, are going to be a variance of different types. We can see some of these are like rebounding. That almost sounds like plyometrics, right? But we get into things like lunging. We get into things like a high step down. We talk about rebounding heel raises, standing single leg heel raises. So all those things are going to have different levels of loading peak. And as you can see here, there's different levels of loading peak when it comes to these plyometric exercises. Their overall peak load isn't that high, but we do know the loading rate is pretty quick. And we also know that for some of them, the loading impulse can be higher as well, especially if it's a lunge with a trailing leg that you're doing slowly. That can be a lot of load impulse, so time spent loading. So again, prioritize the loading peak first, then let's start to transition to adding in some of the loading rate to make it quicker. But since patients have a variance of pain responses here, we want to be careful. If they're having pain, slow down the exercise, keep the loading peak somewhat lower, but progress that first. Also important to note here is that when we're starting to introduce these exercises, we're starting to make a slower plyometric activity. I wouldn't call a box jump, for example, a plyometric exercise. I'd call that a strengthening exercise that you're getting up onto a box. However, if you make those jumps quicker in succession, that starts to become more of a plyometric exercise. So what do we want to do when it comes to the plyometric loading? Well, again, we're using our load test, our single leg heel raises, to be able to understand if patients can tolerate this, and we can make that quicker as well to be able to understand if people can take that under load, under a higher rate of speed. We always want to start with our base test at the 60 beats per minute. However, as we get into jumping and hopping, again, remember the patient must have adequate hip and knee stabilizers. But this is where we can really work on plyometrics. One of the key parts of this is going to be to decrease the amount of to keep the ground contact time high when we're doing plyometrics to start with. That's going to give more time to work on impact load acceptance and the explosive concentric part of the jump as well. That's also going to make it so the patient doesn't incorporate that stretch and lengthen, basically the plyometric aspect of lengthening the tendon quickly and then shortening it really quickly and getting an explosive high peak load out of it. That's going to help to get patients to be able to slowly transition their loading rate. So here we're talking about things like a double leg jump, a double leg hop, forward single leg hops. And then as we get through this process and patients can start a return to run program during this time, we then talk about tier 4. Some patients are going to need a lot of tier 4 because they might want to get back to running a marathon. Other folks may only need a little bit of tier 4. It really starts to depend on what the patient goals are. But we can see drop jumps, for example, are going to be less ground contact time. We have lateral hopping and forward leg hops, single leg, are going to be the highest load. And those are going to be our progressions of different loads for different phases of Achilles tendinopathy rehab. Again, we want to work on all the high weight stuff first. We want to focus and make sure our patients have really good strength through weight to be able to give them that load before we start to add in things like jumping and hopping. The strength is going to make the foundation, then we can add to it with increasing our amount of loading rate and things like that. All of that is going to be a really, really good way to go about Achilles tendinopathy rehab. A couple notes here. We do want to think about Achilles tendinopathy and how we're going to be able to get patients running again. We want to take a look at things like excessive dorsiflexion at initial contact, forefoot strike, or without the heel touching on the ground during the stride. Also, excessive stride length and vertical oscillation can be factors as well. And then we want to be careful with patients with Achilles rehab going on hills and doing speed training early on. That puts a lot of tension and compressive forces on the Achilles tendon.